These are my disclosures. None of them are relevant. So Dr. Raj mentioned this morning that almost every patient with POTS has fatigue, and in research survey studies, that number is greater than 90%. I think it's closer to 100%. And in fact, I think this is probably the most common symptom of POTS, and probably the most disabling. When you ask patients what is the most debilitating for them, fatigue is usually the answer. Some patients have sleepiness, but I think that's a minority, that's a subtype, and we'll talk about that. I think that most patients have the opposite of that. They have insomnia, or trouble, which we define as trouble falling asleep, trouble staying asleep, or inappropriate morning awakenings with daytime symptoms. Many patients also have a delayed sleep phase, which sort of feeds into the insomnia, and we'll talk about why that could be. And several groups have shown that this fatigue, sleep disruption, these cognitive impairments are directly correlated with reduced quality of life and actually suicidal ideation in some more recent publications. So these are very debilitating symptoms for patients. So when I see a patient in the sleep clinic, we always try to distinguish sleepiness from fatigue, and they're different. So sleepiness is a little more straightforward. If I put you in a dark room with a comfortable bed, would you fall asleep right now? If the answer is yes, then you're sleepy. If you fall asleep during this lecture, then you're sleepy right now. So it's simply put just the desire to sleep. Fatigue is, I think of it more as a body fatigue, sort of muscle fatigue. How do you feel if you ran a marathon? So these are what most patients with POTS experience. Although they can also have sleepiness, you can have both. But I think the majority have fatigue. Some also have sleepiness. I've never met one that just has sleepiness. And there are dozens of reasons for fatigue. There's a lot of medical reasons for fatigue. I think most patients with chronic medical disease have fatigue for that reason. Deconditioning, which is also common in POTS, can produce fatigue. So this is one interesting paper I came across. We talk about the correlation with chronic fatigue syndrome in POTS. Maybe a third of patients with chronic fatigue syndrome have POTS. But in this paper, they took all patients with chronic fatigue syndrome and subdivided those patients that also had POTS. And interestingly, the graph on the left, you can see the patients with POTS scored lower on sleepiness scales. ESS is the Epworth Sleepiness Score, that kind of standardized questionnaire we use for sleepiness. So those patients that had chronic fatigue syndrome who also had POTS were less sleepy, although they all scored the highest possible score on the fatigue. So there's something about POTS that maybe is kind of inversely correlated with producing sleepiness in these patients. On the flip side, when you look at the primary sleep literature, there's a condition called idiopathic hypersomnia, which I view as very similar to POTS on the primary sleep side. And a group at Emory, who does a lot of research on this, showed that when they use chronic fatigue syndrome criteria in this group of patients who are extremely sleepy, about 20% of those patients meet criteria for CFS. So it's common and it's overlapping, and it can be quite confusing. So the literature on POTS, what does it teach us? Not much so far. There have been several studies that have looked at objective sleep measurements, and we'll get into these. Not much has come out of these studies. There's not really been any clear single abnormality on polysomnogram, PSG, or sleep studies, or on multiple sleep latency studies or nap studies. We've also learned that patients probably sleep more than they think they do, like most of us do. However, the sleep for some reason is not refreshing. So there is probably some sleep state misperception, and we can get into possibly why that could be. They tend to have a delayed sleep phase. They're more night owls. Most of them have insomnia, though some have hypersomnia, like I mentioned, and a small minority may also have mild obstructive sleep apnea, and that's probably more common in the Ehlers-Danlos subgroup. So before we get into those studies, I just want to briefly go through how we can measure autonomic tone during sleep. This would all be done in a research setting. We don't do this in clinical practice. The first method is peripheral arterial tone, which is produces the graphs that you've seen in the earlier talks, using some of the phenomena that you can see on the right here with the tilt table. This is not very applicable to sleep. It's kind of invasive. It makes your finger go numb, so it's hard to do this during a sleep study. We can measure blood pressure indirectly using pulse transit time from a pulse oximeter, but it's invalidated by any arrhythmias, any movements, so it's not a very accurate measurement. Heart rate variability is the most commonly researched method, and then microneurography. So I wish I had a pointer here, but you can see the blood pressure. This is on a sleep study using the pulse transit time, which just uses a pulse ox. But this is in a patient with severe sleep apnea. And I want you to just look at the, first of all, the blood pressure spikes there with each apnea, which is common due to increased sympathetic tone. But also, if we look down towards the bottom of the graph here, you can see those obvious periods of apnea. There's no breathing. And this is not what a patient with POTS would have. So I'll show you a representative example of sleep disordered breathing in POTS. It doesn't look like this. But this can produce some interesting results, not as applicable in POTS patients because it's really primarily looking at blood pressure. Heart rate variability is what's most commonly referenced in the literature, the most common measurement of autonomic tone during sleep. So this uses spectral analysis of the R-to-R interval to produce two signals, which we break up into low frequency, high frequency. It's very technical, don't ask me the specifics, but really what you need to know is low frequency is approximate to sympathetic tone, high frequency to parasympathetic tone. And it's often expressed in a ratio. You'll see LF to HF ratio. So if you have a higher ratio, that's indicative of greater sympathetic tone, lower ratio, greater parasympathetic tone. And this was done in a few POTS sleep studies. The most direct measurement of autonomic tone during sleep, which is the most invasive but can produce very interesting results, is microneurography. This has not been done in POTS. It will be very interesting to do. There's a very tiny tungsten needle electrode that is placed in the unmyelinated sympathetic nerves of the peripheral nerves in the leg. And you can see these very interesting sympathetic bursts. So if you look at the graph on the right here, this was work done by Viren Summers' group. This is normal sleep in all of us. This is what our autonomic tone, our sympathetic tone is during wake and sleep. So you can see on the top there, we sort of have these bursts of sympathetic tone. We're having all this right now. When we fall asleep, when we get drowsy, that reduces. And as we get into progressively deeper sleep, as our sympathetic tone goes down, that burst activity goes down as well. And what was mentioned by Dr. Grubb, that blood pressure has these big spikes during REM sleep, that's because when we're dreaming, we do have extremely high spikes of sympathetic tone, and you can see that in the furthest graph on the bottom right there. So these are all potential techniques for future studies, and this is hopefully something we'll think about going forward with future research. Some brief definitions. How many of you all practice sleep medicine? Is there anyone in the room that board certified? Okay, great. So these are the definitions that we throw around, the acronyms that you'll see in all these studies. So sleep onset latency, just like it sounds, when we turn the lights off, how fast do you fall asleep? Wake after sleep onset is basically time spent awake in the middle of the night after you fall asleep and wake up. That's sort of that maintenance insomnia. Sleep efficiency is simply percent of time that you are in the bed sleeping. So we divide time in bed by time asleep, and then total sleep time is, total amount of sleep. So the first group that looked at sleep in POTS, to my knowledge, was the Vanderbilt group, and they did sort of three studies. The first study was a survey study where they assessed quality of sleep and correlated that with quality of life. So the worse you sleep, the worse you feel, which is not surprising. On a follow-up study, they did actigraphy, which is kind of like a Fitbit, where they measure body movement and they can equate that to sleep time and amount of sleep. So this is where they also gave patients sleep diaries. So this is where they kind of found that patients, they thought they fell asleep in 56 minutes on average. They actually fell asleep in 37 minutes. So there may be some sort of misperception there. The patients with lower sleep efficiency correlated with worse symptoms, but their sleep studies were otherwise normal. But interestingly, the standing norepinephrine levels, the higher those were, the worse their sleep onset latency and wake after sleep onset. So kind of the worse their insomnia was. They found a negative correlation between how good the patient slept and how robust their postural tachycardia was. And they found a negative correlation between REM sleep percentage and sort of how robust that tachycardia was. So a lot of patients ask, kind of fixated on kind of percent of REM. Am I getting enough REM? Am I getting enough deep sleep? We don't really know. We kind of have general ranges of what's normal for each person. But you can think of REM as, if there's a reduction in REM, that's a marker of sleep disruption. Because REM is a fairly light stage of sleep. So if something's going to wake us up, it's much more likely to do that during REM. So if a patient has reduced REM, we kind of think there's something there that's disrupting their sleep. But we haven't really been able to get more kind of specific than that. So the second group out of Germany, did PSG data on about 38 patients with POTS. They found normal sleep onset, sleep efficiency, total sleep time. They also used frequency analysis to look at those sympathetic, parasympathetic components, which I mentioned. And they found a slight reduction in LFHF, so that would indicate kind of decreased sympathetic tone. But that was only during sleep stage transitions, so it didn't really kind of explain the symptoms that POTS patients have. Otherwise, all the ratios and the frequencies were normal. So then a group out of London did a similar study, also found normal data on PSG. They also did NAP studies on a subset of sleepy patients. So this is the MSLT test, is how we diagnose narcolepsy. Basically, do a sleep study and have a patient stay the next day, do a series of naps, measure how quickly they fall asleep. Narcoleptics fall asleep on average in like 3 minutes. Kind of define objective sleepiness as less than 10 minutes. POTS patients had all normal sleep latencies. So they found some kind of minor abnormalities, slight reduction in REM, reduction in sleep efficiency, but they weren't dramatically different compared to controls. So when we looked at our patients, 18 patients, looking at their sleep studies, also found similar results, pretty normal. We did sleep diaries and circadian rhythm questionnaires as well in those patients. We did find in our group that about 68% had mild OSA, but there's a kind of running joke, if you have a sleep study at Stanford, you're going to get diagnosed with sleep apnea. Christian Guilleminault, who sadly passed away 2 weeks ago, sort of the pioneer of sleep medicine. Very, very sleep disorder breathing centric, so he's very focused on breathing, so we tend to be a little more sensitive in diagnosing this. But interestingly, if we look back at the subset of patients that had sleep apnea, 28% of the patients in our group that had EDS had sleep apnea, so there might be something there. There was some sleep state misperception, as the Vanderbilt group showed, that patients thought they slept worse on their sleep diaries. And we didn't find that patients were sleepy, their Epworths were normal, they were very fatigued. And they tended to be night owls, which we'll get into. So there are a couple papers on sleep apnea and EDS. It makes sense if there's connective tissue laxity that's also going to affect the upper airway and the pharynx and lead to upper airway collapse during sleep. But what you see on a sleep study is very different from that first slide that I showed you where there's apneas. So we call this flow limitation, and in fact, this probably wouldn't even be scored as abnormal on a sleep study report. There is no desaturation, there's no pause in breathing, but you can see this kind of flat top response on that nasal airflow. And this is what Christian Guilleminault was very kind of passionate about, is patients with this sometimes have more debilitating symptoms than 400-pound patient with an apnea every minute. There's something about this mild flow limitation that may increase intrathoracic pressure. Patients can still wake up frequently from this, but it's just not something that is scored in a typical clinical sleep study. So if all the data is fairly normal, why are POTS patients so fatigued? So these are just some theories that we came up with. None of these have been studied, but hopefully there's grounds for future research. Increased number of microarousals. So the sleep studies are really looking at macro sleep, but we don't really look at microsleep. Hyperarousal due to this hyperadrenergic state that a lot of patients have. Increased brain activity during sleep, and then of course limited sleep time and insomnia. And a lot of this comes from insomnia literature, which I think has a wealth of information to learn from in thinking about sleep in POTS. So why do POTS patients have insomnia? So this hyperarousal state, this is something that is commonly noticed in insomnia patients is what we call tired but wired. This hyperaginergic state, patients constantly feel fatigued, but they can never quiet down and sleep. And this may be due to kind of heightened hypothalamic pituitary adrenal tone, increased catecholamine secretion, kind of excessive cortical activity during wake, but also during sleep. Patients with POTS also have a lot of somatic symptoms. They have a lot of POTS symptoms at night, chest pain, night sweats, headaches, which we just heard about, GI symptoms, pain. Those can either prevent them from falling asleep or they can wake them up out of sleep, and I think out of REM sleep. And I've noticed this especially in the EDS patients. They tend to have more of this fight or flight response, kind of wakes them up out of REM, hyperaginergic state. And they also have probably increased interoception, which is this term of just feeling your own body sensations. They're much more aware of their heartbeat, of their GI, function. So this kind of central sensitization may also be inhibiting sleep. They also have delayed sleep phase, which we'll again get into. This reinforces insomnia, and this leads to this tired but wired phenotype. So one study showed that patients with POTS are non-dippers. So dipping is normal for all of us when we fall asleep. Blood pressure and heart rate reduce 10 to 20%. And this has only been done in one study, but more than 50% of patients with POTS do not dip their blood pressure. There's also a phenomenon called cyclic alternating pattern, or CAP, or microarousals, and none of this, again, has really been done in POTS. This comes from chronic fatigue literature, where we can see these alternating periods of fast activity in the EEG coupled with a slow activity, and this kind of comes in cycles, and this may be reflective of some kind of sleep fragmentation on a circuit. But CFS patients have about 50% more of these than controls in some studies, and it would be interesting to look at this in POTS. There was one study looking at cortisol. This was in children with POTS. They showed that patients with POTS, children with POTS had higher daytime cortisol levels, and when we fall asleep, cortisol is very low. It kind of peaks right at awakening. So this can be a marker of sleep fragmentation. Whenever we wake up, there's kind of bursts of cortisol that are released, and that can spill over to the morning. And they showed that in this study that the higher the cortisol level, the worse the POTS symptoms were. So there's also some precedent for elevated norepinephrine level in the insomnia literature. Patients who don't sleep as much have increased norepinephrine. This may also be playing a role in the hyperaginergic phenotype. And then also from the insomnia literature, you can see that this is what a heart rate is, a normal heart rate in the top left graph. Just like blood pressure dips and drops when we sleep, heart rate does the same thing. But in patients with insomnia, it doesn't do it as robustly. And if this was done in POTS patients, I would put money on the fact it would kind of show similar results. So there's also been imaging studies and EEG studies that show increased brain activity during sleep, and this again from the insomnia literature. Patients with insomnia have increased activation during sleep of areas that are important in arousal, like the prefrontal cortex, areas of the thalamus, and they also have faster EEG activity. So why do POTS patients have a delayed sleep phase? Why are they night owls? Well, age is one factor. I mean, when we're younger, we all tend to have a more delayed circadian rhythm. As we get older, that shifts earlier and earlier. They have insomnia, so that kind of reinforces them staying up later and later. Many patients feel their best late in the evening, and as a result, they kind of want to hold on to that and not go to bed. So I feel like a lot of patients do resist the bed, which kind of reinforces that. Another interesting component of this, beta blockers may inhibit melatonin secretion. So in a couple studies have shown that beta blockers act on melatonin receptors, inhibit melatonin release. So if we're giving beta blockers at night for the tachycardia, we might want to think about giving us a low dose of melatonin as well around bedtime to kind of help counteract that. And usually use around 3 milligrams 30 minutes before bedtime. kind of rushing through this. I know we want to stay on time. So how do we just approach, in general, sleep evaluation of a patient with POTS? A lot of it is really the same as any patient with a sleep disorder. We want to get a sense of when they go to bed, which is not the same as the time that they get in bed. I mean, a lot of patients with POTS, for various reasons, probably spend too much time in bed. They feel better in bed, but that's maladaptive. It really works against the sleep problems they're having. You know, when they fall asleep, what time they wake up in the morning. We try to keep consistency in all of this. Do they have symptoms of sleep apnea, which pretty much just asks snoring? You know, if a patient snores, they're fatigued, they should probably have a sleep study, period. Restless leg syndrome, so this is a very overlooked condition, and even as a neurologist, we got very little training in this. So about 25% of women probably have RLS. Every patient with RLS has insomnia, they can't sleep. So this is always something to think about and ask patients. So it's defined by an unpleasant urge to move the legs, so it's an internal feeling, it's uncomfortable. It gets better with movement, and it is much more prominent in the evening, has a circadian component to it. Symptoms of narcolepsy, those are rare, won't get into those. And then we always ask about the somatic symptoms of POTS, so those keep patients up. So again, this is just a mnemonic you can remember for restless legs is urge. Unpleasant sensation, urge to move, worse with rest, gets better with movement, worse in the evening. And this is a single item questionnaire that has very high sensitivity and specificity for RLS. So my last couple slides is some data that we recently gathered in a group of patients with primary hypersomnia. So these are not POTS patients, but I think this is very interesting because, like I said, there is I think that subgroup of patients that are very sleepy. They're hypersomnia, almost like narcolepsy patients. So we did an online survey study similar to what Dr. Raj did, using the patient advocacy group of the Hypersomnia Foundation. And we administered Compass 31 scores to all these patients with a diagnosis of idiopathic hypersomnia. And we found a very, not surprising in some ways, but severity of autonomic symptoms was very surprising. So the bottom line, just to orient you here actually, so the three groups here, the furthest left is online patients, which were kind of about 200 patients. Then confirmed patients, which were our own patients that we had confirmed in person with this disease, and then controls on the right. So the dashed lines there, the bottom one is a normal score on the compass, and the top bar there is a severe autonomic failure. So that's something that you'd see in like a patient with MSA, that type of score. So these primary hypersomnia patients have a severe autonomic burden, and we had a line in there where they can write their diagnosis. The most common diagnosis was POTS. And interestingly, the most significant subscore on the compass was orthostatic intolerance in this kind of primary hypersomnia group. So I think part of it gets into how these patients are seen by physicians, which subspecialty they enter from, and which diagnosis they get. But there are so many overlaps here that need to be disentangled. Like all of the other studies in our patients, the severity of their symptoms was positively correlated with sleepiness. It was also positively correlated with fatigue and inversely correlated with quality of life. So I'll just leave this for your slides. This is a kind of flow sheet that we developed in approaching sleep and POTS. All of this is in an article in Autonomic Neuroscience that was published as part of the special edition, which is a great resource. It encompasses all of these topics that have been reviewed today. So in summary, based on current literature, it is difficult to state that the sleep complaints of POTS are a result of a primary sleep disorder. I think a more plausible explanation is that patients experience disrupted sleep from a combination of factors such as body fatigue, chronic pain, possible hyperactivity of arousal networks, and probably some sleep state misperception. And I think like chronic fatigue syndrome, fibromyalgia, EDS, POTS is multifactorial. It's a chronic illness with many possible causes, so there's probably not one single sleep disorder that's explaining all of these symptoms, and nor is there one treatment algorithm. And that's all I have. Thank you.